Welcome to PRISM Rounds, the audio journal club for pulmonary, critical care, and sleep clinicians.
Thanks for having me back.
Today we are diving into a really fascinating deep dive on the 2025 NEJM trial, specifically the Phase 3 trial of inhaled Molgramostim in autoimmune pulmonary alveolar proteinosis.
Right, and just to give everyone the bottom line right up front so we know where we're headed. In autoimmune PAP, inhaled Molgramostim improves DLCO, it improves quality of life, and it's really well tolerated.
Which is huge. Right?
Oh, absolutely. It represents a likely disease-modifying therapy that may actually replace whole-lung lavage in a lot of these patients.
You know, it's funny. In pulmonary and critical care, we are so used to diagnosing structural or just purely inflammatory lung disease.
Yeah, the classic bread and butter stuff.
Exactly. A patient comes in with progressive dyspnea, you get the high-res CT, and you see like usual interstitial pneumonia or, emphysematous changes.
The mechanism is just right there staring at you on the scan.
Right. You see the fibroblastic proliferation or the alveolar destruction, and it just makes intuitive mechanical sense to us.
We know those pathways in our sleep.
We do. But then you get a patient with autoimmune PAP, and suddenly those traditional paradigms they don't fit at all.
Not even a little bit. You're not dealing with a destructive inflammatory cascade or like a fibrotic remodeling of the interstitium.
No, you're looking at a disease that essentially slowly suffocates patients from the inside out.
Which is a terrifying clinical picture when you actually see it.
It really is. And today, for you listening, we're going to explore how moving away from a treatment that honestly resembles medieval plumbing.
Oh, that is exactly what it is.
Right. Moving from that to a highly precise, localized inhaler, it's just completely rewriting the rules for how we treat this.
It's a total paradigm shift. I think to really appreciate the IMPALA-2 trial, we have to start down at the alveolar epithelium.
Let's do it. Walk us through the normal physiology first.
So in a healthy lung, you have these type 2 pneumocytes, and they are constantly secreting pulmonary surfactant.
And that surfactant is, it's mostly lipids, right?
Yeah, it's about 90% lipids, specifically DPPC, and then maybe 10% specialized surfactant proteins like SBA, B, C, and D.
And we all learn in med school that this surfactant is super critical for reducing alveolar surface tension so the lungs don't just collapse at the end of expiration.
Exactly. But making the surfactant is really only half of the equation. There has to be a way to clear it out.
Because otherwise the alveoli would just fill up with it like a bathtub left running.
Right. There has to be a reciprocal degradation pathway, and that's where the alveolar macrophages come in.
Our friendly neighborhood garbage collector.
Exactly. These specialized immune cells are the resident garbage collectors of the distal air spaces.
But their main job isn't even just fighting off bugs, is it?
Not really, no. I mean, they do immune surveillance, sure, but their primary continuous job is the catabolism of spent surfactant.
So they just sit there and eat the used lipids and proteins all day?
Pretty much. They ingest it, they process it, and then they efflux the cholesterol byproducts out. It's this highly regulated self-cleaning cycle.
Okay, so in autoimmune PAP, that self-cleaning cycle just completely breaks down.
It comes to a grinding halt. And the crazy thing is the type 2 pneumocytes are totally fine.
Wait, really? So they're just pumping out normal surfactant?
Completely normal surfactant at a completely normal rate. It's not a production problem at all.
It's entirely a clearance failure. I always like to think of like an analogy for the patients, right? Imagine your alveoli are like tiny air filters.
I like that.
In PAP, it's not that the body is making toxic sludge. It's that the normal exhaust is fine, but the filter is broken. It's a clogged filter.
That's a great way to put it. The macrophages are the filter, and when they clog, that lipid-rich fluid just relentlessly backs up.
It just fills the alveolar space completely.
And that distinction between production and clearance is so vital for understanding how the patient actually presents to you in the clinic.
Because it's a really insidious onset, right? They don't just wake up one day hypoxic.
No, it's super gradual. The alveoli are slowly filling with this dense, lipoproteinaceous material, so they get this progressive dyspnea on exertion.
And usually an unexplained dry cough and just profound fatigue.
Yeah, because as the spaces fill up, you get a massive ventilation-perfusion mismatch.
Right, the blood is still flowing past the alveoli just fine.
The perfusion is there, but the oxygen absolutely cannot diffuse through that thick, nasty layer of surfactant sludge.
Which leads right to the progressive hypoxemia.
Yeah.
When you grab a high-res CT, the imaging is just wild.
Oh, it's one of the most distinctive radiologic findings we have in pulmonary medicine. The classic crazy paving pattern.
Crazy paving. It literally looks like irregularly laid paving stones on the scan.
It does. You get these bilateral symmetric ground glass opacities, but then they have superimposed septal thickening.
And the ground glass haze is the actual surfactant, right?
Yeah.
Sitting in the air spaces.
Exactly. And the thickened septa, those are the distended lymphatic vessels desperately trying to drain all this excess lipid and just totally failing.
It's basically a radiologic picture of an overwhelmed plumbing system.
That's exactly what it is. But to understand why the macrophages stop working, we have to dig into the molecular level.
The why? Why do these perfectly good garbage collectors just go on strike?
The NEJM editorial goes incredibly deep into this, and it all centers around one specific cytokine.
GM-CSF, granulocyte macrophage colony stimulating factor.
Yes. GM-CSF is basically the master regulatory signal for these alveolar macrophages.
So how does it normally work when everything is healthy?
Well, in the lung, GM-CSF binds to this specific heterodimeric receptor on the surface of the macrophage.
And that binding kicks off a signaling cascade, right?
Yeah, the JAK2 STACT5 cascade. And that cascade ultimately flips a highly specific genetic switch.
This is the PU.1 transcription factor we were reading about.
Got it. Think of PU.1 as like the master software program.
Right. It tells the immature monocyte to fully differentiate into a mature alveolar macrophage.
Exactly. But more importantly for PAP, PU.1 upregulates the expression of ATP-binding cassette transporters.
The lipid transport proteins, the ABCA1 and ABCG1 pumps.
Yes. Those are the actual molecular pumps on the surface of the macrophage that let it spit out the cholesterol after it eats the surfactant.
Okay, so without GM-CSF to turn on PU.1, those cholesterol efflux pumps they never get built.
They're never built. The macrophage can eat, but it can't digest and export.
Which brings us to the actual autoimmune part of autoimmune PAP. The patient's body literally sabotages this whole system.
It's a masterpiece of molecular sabotage, really. The immune system develops these high-affinity neutralizing IgG autoantibodies.
And they target the patient's own endogenous GM-CSF.
Right. These autoantibodies circulate in the blood, they spill over into the lung lining fluid, and they just aggressively bind to the GM-CSF molecules.
They just physically tackle the signal before it can reach the macrophage receptor.
Exactly. So the GM-CSF is there, but it's neutralized. The signal never gets through.
The PU.1 switch stays off. And the cellular result is just absolute chaos in the alveolus.
Total chaos. The macrophages are still there, and they're still trying to do their job by eating the surfactant.
But because they don't have those lipid pumps, they just gorge themselves on cholesterol.
They literally become engorged. The pathology term is foamy macrophages.
Foamy macrophages. It sounds almost cute, but it's really not.
Not at all. If you do a BAL and look under the microscope, they're these massively distended, totally ineffective husks packed with lipid vacuoles.
And since they are incapacitated, the alveoli just fill up with insoluble surfactant, sediment, debris, and even solid cholesterol clefts.
It is a horrific microscopic environment. You have this delicate alveolar capillary membrane that's supposed to be micrometers thin for gas exchange.
And instead, it's buried under a thick, milky sludge.
Exactly. So taking that pathophysiology, how do we historically treat a patient who presents with this?
Well, this is where it gets kind of brutal. Because we've known about this disease since, the late 50s?
Yeah, 1958, long before we understood the autoantibody mechanism.
Right, so the treatment that evolved was purely mechanical.
Yeah.
If the lungs are full of sludge, you just wash them out.
Whole lung lavage, the standard of care.
I mean, when you really break down the mechanics of this procedure, it is astonishingly invasive.
It really is. You're taking a patient whose main problem is that their lungs are full of fluid.
And you treat them by intentionally drowning one of their lungs with dozens of liters of saline.
It's so counterintuitive, but it's an incredibly resource-intensive, highly orchestrated procedure.
You need general anesthesia, a paralyzed patient, an expert thoracic anesthesia team.
Yeah, and you have to insert a huge double-lumen endotracheal tube so you can completely isolate the right lung from the left lung.
Because you have to keep the patient alive by ventilating one lung while you deliberately flood the other one with warm saline.
Right. You fill the diseased lung with like 1 to 2 liters of saline at a time. You let it dwell.
And then the clinical team literally beats on the patient's chest. aggressive manual chest percussion.
They are physically trying to knock that thick adherent sediment loose from the alveolar walls.
Like I said, medieval plumbing, ICU-level broncho pool cleaning.
It's exactly like trying to clean a highly delicate biological sponge with a fire hose.
And then you just drain it out via gravity. And the first few liters that come out...
Oh, it looks completely opaque. It's this thick, milky, yellowish fluid.
And you just repeat this over and over. What is it, like up to 50 liters of saline per lung?
Easily up to 50 liters before the effluent finally starts to run clear.
50 liters of fluid introduced into an organ that evolved strictly to handle air. The physiological toll must be just massive.
It's deeply traumatic. You are intentionally creating a massive right-to-left intrapulmonary shunt during the procedure.
Right, blood is perfusing the flooded lung, picking up zero oxygen, and mixing right back into the systemic circulation.
So transient severe hypoxemia is incredibly common. Plus, you run the risk of airway bleeding or displacing that double lumen tube.
Which could be fatal if the saline floods into the ventilated lung.
Absolutely. And there's the risk of pneumothorax just from the massive hydrostatic pressures.
Okay, I have to pause here. From a pure pathophysiology standpoint, this is wild.
Oh, I know what you're going to say.
We just established the root cause is a precise molecular defect, right? An autoantibody blocking GM-CSF.
Right.
So why on earth are we treating this with a garden hose instead of fixing the cellular defect? Holding Lavage does absolutely nothing to stop the autoantibodies.
And that exact frustration is what drove pulmonary researchers for the last 2 decades.
Because it's just a mechanical Band-Aid.
Exactly. You wash away the downstream symptom, but the upstream pathogenesis is totally untouched. The autoantibodies are still there.
The macrophages are still paralyzed, so the second they wake up from anesthesia,
the surfactant just starts accumulating all over again. The relief is totally temporary.
which means they have to come back and do this brutal procedure again.
Yeah, typically every 12 to 15 months, just to maintain baseline oxygenation and stay alive.
It's just a grueling cycle, which perfectly sets the stage for IMPALA-2.
It really does. The sheer futility of the lavage led researchers to search for a true bench-to-bedside targeted therapy.
They understood the mechanism, so they built an intervention to intercept it. Let's talk about the drug.
The drug is Molgramostim. It's a recombinant human GM-CSF.
So it's basically a synthetic version of the cytokine produced in E. coli.
Right. And because it's from E. coli, it's non-glycosylated, but studies show it still binds the receptor and activates PU.1 just fine.
Oh, wait, let me push back on this, because if I'm the attending looking at this, there's a glaring logical hurdle.
Lay it on me.
If the patient's blood is absolutely saturated with high affinity, neutralizing autoantibodies against GM-CSF, won't injecting synthetic GM-CSF just result in the body instantly neutralizing that too? It seems like throwing a drop of water into a systemic sink.
That is brilliant clinical deduction, and it's exactly what happened historically.
Yeah.
Yeah, in the early 2000s, they tried subcutaneous GM-CSF injections, and the results were super mixed.
Because the antibodies just ate it up.
Exactly. The systemic antibodies were too efficient at clearing the drug. Some patients responded, but you had to use massive doses, and the side effects were awful.
So you have to bypass the systemic circulation entirely.
That is the absolute genius of the delivery system in IMPALA-2. They hypothesized that if they could deliver the drug directly to the alveolar space...
They could just outsmart the immune system entirely.
Exactly.
Yeah.
So they formulated Molgramostim to be aerosolized. They used a specific vibrating mesh nebulizer called the eFlow system.
And vibrating mesh is crucial, right? It's not just a standard jet nebulizer like you'd use for albuterol.
No, an ultrasonic vibrating mesh can precisely control the droplet size. It generates an aerosol with a diameter of roughly 2 to 3 micrometers.
Which is the magic number for deep lung deposition.
Right. Too big, it hits the back of the throat. Too small, you just exhale it. 2 to 3 micrometers deposits directly into the distal alveoli.
So by dropping the drug right into the alveolar space, the local concentration of synthetic GM-CSF just completely overwhelms whatever tiny fraction of autoantibodies manage to diffuse into the lung lining.
You overwhelm the local blockade, the drug binds the receptors, PU.1 flips on, the lipid transporters are built, and the macrophages finally wake up.
They wake up and start eating the sludge. It's a profound end run around the immune system.
It's so elegant. So let's look at the trial design, because they really had to prove this worked.
This was a phase 3, double-blind, randomized, placebo-controlled trial. N equals 164 patients with confirmed autoimmune PAP.
Which is a monumental logistical achievement, honestly. The prevalence of this disease is like 6 to 27 cases per million.
So getting 164 of them for an RCT is massive. They randomized them 1-to-1.
Right. Half got the inhaled Molgramostim 300 micrograms once daily, and half got a matching placebo.
And the double-blind phase lasted 48 weeks. But the primary endpoint was measured at 24 weeks.
And the primary endpoint was DLCO, which is vital to understand.
Let's break down why DLCO is the absolute perfect metric for this. Because we're not looking at FEV1 here.
Right. It's not asthma or COPD. It's a disease of gas exchange. DLCO measures the diffusing capacity of the lungs for carbon monoxide.
It essentially tells you how well gas transfers from the airspace across the membrane into the red blood cells.
Exactly. And carbon monoxide is used because its affinity for hemoglobin is so high, the transfer is entirely limited by diffusion, not blood flow.
So if your alveoli are lined with a thick physical barrier of lipid sludge, the carbon monoxide just can't get across.
And your DLCO plummets.
It's an incredibly precise surrogate marker for how clogged the filter is.
Exactly. If the drug works, the macrophages eat the sludge, the barrier thins out, and the DLCO number should go up.
Okay, so did it work? Did the daily inhaler actually clear the lungs better than placebo?
The data is highly compelling. At week 24, the absolute improvement in DLCO was 9.8 percentage points in the Molgramostim group.
Wow. And the placebo group?
Only 3.8 points. So we're looking at a treatment difference of exactly 6.0 percentage points. P-value less than 0.001.
Okay, statistically significant, absolutely. But let me play skeptic for a second.
Go for it.
Is a 6% difference actually noticeable to a patient who feels like they are suffocating? Does that translate clinically?
That is the most important question. How do we define the minimal clinically important difference, or MCID?
Right, because there isn't a universally validated MCID specifically for autoimmune PAP, is there?
No, because it's so rare. But we routinely borrow context from other fibrotic lung diseases like IPF.
Idiopathic pulmonary fibrosis.
Right. In IPF, clinical guidelines generally say a 10 percentage point change in DLCO is the gold standard threshold for a profoundly meaningful clinical difference.
Okay, and the patients on the drug achieved a 9.8-point baseline improvement by week 24.
Exactly. They are virtually sitting exactly on that threshold of real-world impact.
And it gets even better when you look at the 48-week data, doesn't it?
It does. The benefit was sustained, and it actually continued to grow. By week 48, they reached an 11.6 percentage point improvement.
That implies the macrophages didn't just clear the top layer and stop. As long as the drug was there, they kept chipping away at the burden.
Exactly, driving them well past that 10-point threshold. But they also tracked quality of life using the St. George's Respiratory Questionnaire.
The SGRQ. I love that survey because it doesn't just ask if they are short of breath. It measures how the disease impacts their daily life.
Right, getting dressed, social functioning, all of that. And remember, a lower score is better on the SGRQ.
Lower means less disease burden. What were the numbers?
At 24 weeks, the score decreased by 11.5 points in the drug group versus only a 4.9-point drop in the placebo arm.
And for context, in COPD, an improvement of just 4 points is considered clinically meaningful.
So they nearly tripled that threshold. The patients are explicitly telling us their day-to-day lives are dramatically better.
And they also did exercise capacity testing, right? Measured in METs.
Yeah, a rigorous 31-stage treadmill test. The gains were modest. A 1.1 MET increase for the drug versus 0.7 for placebo.
So a 0.4 MET treatment difference, which sounds tiny.
It sounds small, but in cardiopulmonary rehab, a 0.5 MET improvement is heavily recognized as a critical indicator of functional reserve.
So it's a small but physiologically consistent win. The alveolar membrane is thinner, gas diffuses better, so the systemic engine can run just a little harder.
Exactly. And we shouldn't forget the exploratory endpoints, like the reduction in rescue lung lavages.
Oh, this is massive. What did that look like?
Over 48 weeks, 13% of the placebo group deteriorated so much they needed a rescue lavage. In the Molgramostim group, only 7%.
It almost cut the need for the garden hose treatment in half.
Which is a profound reduction in procedural trauma for those patients.
Okay, let's pivot to bedside translation and safety. Because a drug that works but is toxic is useless to us.
Totally. But the safety profile here is highly reassuring. No mortality signal at all.
Most adverse events were mild to moderate. Though I did notice a slightly higher incidence of COVID-19 in the drug group.
Yeah, 22% versus 10% on placebo.
And diarrhea was higher too, right? 11% versus 2%.
Right. Those are real signals. With the COVID, we are fundamentally modulating macrophage activity in the exact tissue bed where viral entry happens, so it makes sense.
And the diarrhea.
Well, when you use a nebulizer, a lot of the aerosol impacts the oropharynx and gets swallowed. The gut has resident macrophages with GM-CSF receptors too.
So the swallowed drug is probably causing mild inflammatory activation in the gut. That's super logical.
But importantly, it rarely led to dropouts. Only 2 patients out of 82 in the active arm had to stop the drug because of side effects.
I mean, when the alternative is a progressively fatal suffocating disease and repeated whole lung lavages, a mildly increased risk of diarrhea is a totally acceptable trade-off.
Universally acceptable. So synthesizing this for the bedside, this feels like a tectonic shift in our algorithmic approach.
It is a monumental shift.
Yeah.
It moves this from a procedural surgical disease to a medically managed one.
It's likely the first true disease-modifying therapy we have for APAP.
But let me ask you a specific clinical question.
Yeah.
You're Annette again. A patient with known APA presents crashing in the ICU.
Okay.
Profoundly hypoxic, massive A gradient, dropping saturations on high flow. Is this inhaler the silver bullet you give them right then?
Absolutely not. And that is such a crucial bedside distinction. This is not an acute rescue therapy.
Walk us through the clinical reasoning on that. If it fixes the exact mechanism, why not use it when they're crashing?
It entirely comes down to the biological timeline. The drug has to turn on PU.1, build the lipid pumps, and then the cells have to physically eat mountains of sludge.
Which takes weeks and months.
Exactly. That's why the primary endpoint was at 24 weeks. If a patient is crashing, they will die from hypoxemia before the macrophages even wake up.
Right. The mechanical barrier has to be removed immediately.
So for the crashing ICU patient, whole lung lavage is still the absolute standard of care. You have to wash them out to save their life.
But the inhaler is the long game. It's the preventative maintenance.
Exactly. It's a chronic disease management tool for stable symptomatic patients to slowly clear the lungs and prevent the ICU stay in the first place.
That makes total sense. But as with any major trial, we have to look at the limitations.
Yeah.
What did IMPALA-2 not prove?
Right. We have to maintain our critical rigor. First off, the sample size. 164 patients is relatively small.
Small compared to a massive cardiology trial? Sure. But for an orphan disease, it's expected. Still, it means a wider confidence interval.
And reduced statistical power to detect really rare adverse events. Secondly, we are relying on surrogate endpoints.
DLCO and quality of life scores. We don't have hard mortality endpoints.
Exactly. We don't have 10-year data proving this categorically prevents death compared to historical care.
Yeah.
It strongly implies it, but the trial wasn't powered for that.
And that leads to the biggest question. Long-term durability. The trial was 48 weeks. Does this eventually cure them? Like, do the macrophages clear the backlog and then they can stop the inhaler? Or are they on this for the rest of their lives?
The data doesn't definitively answer this yet. But biologically, the systemic B cells are still making the autoantibodies.
So if you stop the daily inhaler, the local GM-CSF levels drop, the macrophages turn back off.
And the lipid sludge will just slowly, inevitably start to build up again.
So we should probably view this as a lifelong maintenance therapy, like taking insulin for type 1 diabetes.
That's the most biologically sound assumption right now. We'll know more when we get years of data from the open label extensions.
And we also noted it didn't completely eliminate the need for lavages. 7% in the drug arm still needed one.
Right. For some patients with really aggressive disease or crazy high antibody titers, the sludge might just outpace the drug-enhanced clearance.
Even so, moving from guaranteed annual 50-liter saline lung washouts to just using a targeted nebulizer with your morning coffee.
It's an incredible leap forward in quality of care. It's a true bench-to-bedside triumph.
I think we should zoom out for a moment to look at the big picture implications, because this trial represents a fascinating proof of concept.
It really does. The strategy of localizing biologic therapies is just brilliant.
Right. Think about rheumatology or immunology. When we face a disease driven by systemic autoantibodies, our reflex is always heavy systemic immunosuppression.
High-dose steroids, rituximab, things that just nuke the whole immune system and carry massive toxicity.
But these investigators did the exact opposite.
Yeah.
They didn't even try to suppress the B cells making the antibodies.
They basically ignored the systemic immune dysfunction entirely.
They just delivered the missing key exactly where the locked door was, the alveolar space. And at a local concentration so high, the systemic antibodies didn't even matter.
It leaves you with this really provocative thought, could this local biologic bypass strategy be the blueprint for other diseases?
That's exactly it. Could we deliver highly concentrated biologics directly to the kidneys in lupus nephritis or the gut in inflammatory bowel disease?
All without having to subject the patient to systemic immune suppression. It's a completely tantalizing frontier.
It really shows why studying ultra-rare orphan diseases is so critical. Solving PAP might unlock new paradigms for all of internal medicine.
The lessons we learn at the microscopic level often have huge macroscopic implications.
Let's summarize the key takeaways from today's deep dive for you listening.
First, autoimmune PAP is a disease of macrophage dysfunction. Autoantibodies neutralize GM-CSF, preventing lipid clearance, and the alveoli slowly fill with surfactant.
Second, the historical standard of care, whole lung lavage, is an invasive, resource-heavy mechanical band-aid that provides only temporary relief.
Third, the Phase 3 IMPALA-2 trial proved that localized inhaled Molgramostim successfully bypasses those autoantibodies. It restores macrophage function and significantly improved alveolar gas exchange,
Which we saw validated by a robust increase in DLCO. And finally, this translates to highly meaningful clinical benefits: better quality of life, modest gains in exercise capacity, and fewer rescue lavages.
It is very likely the new practice-changing standard for the chronic management of stable, symptomatic patients.
It's a phenomenal advancement. Well, thanks for joining PRISM Rounds. This is for education only, not medical advice.
This episode was generated using AI voices for educational purposes.
Yeah.
You may notice occasional mispronunciations of medical terms, drug names, or author names. Thanks for your patience.